Hi, everybody. I'm just going to spend the next half an hour comparing the RVPA conduit to the modified BT shunt. Thank you for having me here today. I have no conflict of interest and I have no commercial support. So the objectives for the next 20-30 minutes are to provide an overview of a historical perspective and a surgical procedure for both the Norwood with the RV to PA conduit and the BT shunt, to compare the two different shunt types, and to highlight general principles of postoperative management and clinical care. So it was actually Bill Norwood who first utilized the RV to PA conduit for stage 1 palliation of hypoplastic left heart syndrome in a study of 16 consecutive patients who entered for stage repair, and this was back in the late 70s, early 80s. And as you can see, there are a variety of approaches that he took, but here in the second approach, he actually utilized the RV to PA conduit, but this early group had really high mortality, so the modified BT shunt became the standard of choice for stage 1 palliation. So it wasn't until, and then he published in 1982, the stage Fontan procedure for a child with hypoplastic left heart syndrome. And then it wasn't until 1998 that Kishimoto and colleagues back in Japan, they were having such bad or high mortality with the stage 1 with the BT shunt, that they revived the RV to PA conduit. And around the same time, Sano and colleagues were doing the same. The difference was that Kishimoto was using a valve conduit, which they had good postoperative success, but then they found the conduit became stenotic over time. And so it was Sano and colleagues who revived this as well, and they used a non-valved PTFE or a polytetrafluoro ethylene PTFE graft, 4 to 5 millimeters, non-valved, and that really improved survival to 84% from what it was previously. So, and that became adopted by many centers. And as Jane Newberger probably went over with the SVC trial, is that the initial outcomes have been better with the Sano, but, and I'm sure she's gone over what we see now. So if we quickly just go over the procedure, the surgical technique varies from center to center, using either a brief period of deep hypothermic cardiac arrest or regional cerebral perfusion, which allows for time to work on the aortic arch restriction. But for both repairs, so there's a PDA ligation, there's a coarctectomy, there's an aortic arch augmentation, an MPA division, and then the DKS operation, or a Damas-K-Stanzel, which is the extensive arch reconstruction with the aorta and the PA. And then for whatever type of surgery you do for pulmonary blood flow, it's either going to be the Sano or the BT shunts. So here you've got the new aortic reconstruction to provide systemic flow. Atrial septectomy is very key to this operation because you do not want to have obstruction to pulmonary venous return to that single heart going out to flowing systemically. And then for the RV to PA conduit, it's to provide pulmonary blood flow. Usually the distal stump of the pulmonary trunk is utilized, usually a 4 to 5 millimeter non-valve conduit via right ventriculotomy incision. And so the technique for doing this has changed, and it's very, it's different from center to center, from surgeon to surgeon. But it used to be that they did a punch hole to put this conduit in. So if you can imagine taking a little chunk out of the RV, now that's not done. And the reason for that was because it's a muscle and it's contracting. So without a free obstruction to flow, it would contract down on itself. But so now what our techniques are changing quite a bit. And in fact, what we're doing here, most of our surgeons, Ram and others and Chris, is they do this thing called the dunking technique. And it's a transmural insertion of an externally reinforced conduit, or the dunk. So they do a reinforced ring conduit. They do a minimal ventriculotomy incision, dunk the conduit in like a straw, and there's a ring reinforced graft so that it prohibits the RV from squeezing in to cause stenosis, and they have better outcomes with this. So it is changing and it is adapting. So this is courtesy of Ram and Mani. So here you can see that they're made an incision. It's a minimally invasive incision to place the conduit. So soon you'll see him bring in the ringed reinforced grafts. There's a lot of movement with the headlights at the moment. And he'll put the conduit, the ring reinforced conduit with the Hagar, and then dunk it in. And so this helps to secure that, and with minimal sutures. So they, as you'll see in a minute, he'll pull open the base where he cut the incision into the RV, and then he'll dunk the conduit in. And so less sutures, and so then less scar tissue, hopefully, with this procedure. It's the PTFT, the polyfluorotetra conduit, and it's a little ring graft. So there he's dunking it in, putting it into the RV, and that has been shown with better outcomes. So that kind of, you get the gist of it here. And then this was just published recently by Jamie Bentham, Chris Baird, and colleagues here. And what they're finding is with the ring reinforced conduit, it's associated with decreased intervention, with a higher pulse pressure, improved PA growth. So again, what we do here isn't necessarily what another surgeon or center may be doing. It's very surgeon and center specific. And in fact, Frank Pagula has tried using this saphenous vein graft because it's got a valve in it, and so to avoid the effects of pulmonary regurgitation, which I'll get into in a minute. So now when we compare the Norwood with the BT shunt, again, you're creating the neo-aorta. This is review for all you guys, utilizing the pulmonary trunk and a diminutive native aorta. An atrial septectomy again, and then the modified BT shunt. It's either from the subclavian artery or the the innominate artery or the right subclavian artery. And it's usually a 3.5 millimeter shunt, but it's really dependent on the weight of the patient. And so the ideal size aids in minimizing the post-operative effects of increased pulmonary blood flow at the expense of systemic blood flow for both shunts, whether it's a BT shunt or an RV to PA conduit. And why people changed to the RVP and conduit, it seemed easier to control that increased pulmonary blood flow and lack of systemic flow because you're only getting flow and systole via that RV to PA conduit, as opposed to the BT shunt, where it's in both systole and diastole, so you get more torrential pulmonary blood flow often. So when we compare the two shunts, so let's look at them individually. So the RV to PA conduit, there's no diastolic steal, meaning that with the BT shunt, you're getting flow in both systole and diastole through that shunt to the lungs. So it's impacting your diastolic blood pressure, where you don't get that in RV to PA conduit. So the benefit of that is that you have increased coronary perfusion, because remember that you perfuse your coronaries in diastole. So if your diastolic blood pressure is a little bit better, then you have better coronary perfusion. However, there's free PR via the conduit. So these kids tend to be a little bit bluer because you're only perfusing in systole. So this is to and fro flow. So therefore, you have decreased respiratory reserve. So if you throw atelectasis or a pneumonia on top of this, these kids are going to be even bluer. And there have been issues with distal PA growth. So both of these surgeries are associated with volume load to a single ventricle, but the reason is different for each. And for the RV to PA conduit, it's because of free PR. And often you get proximal PA stenosis, conduit stenosis rather, not PA, for the RV to PA conduit, but with the ring reinforced graft, hopefully this should be better. RV aneurysm, and there's an incision in the RV. And if you go to an earlier bidirectional Glenn or stage 2, it's usually because of hypoxemia. So with the BT shunt, you've got diastolic steal, you've got lower diastolic blood pressure, wider pulse pressure, decreased coronary perfusion, excessive blood flow because you have flow in both systole and diastole, so your volume low from a single ventricle is usually from excess flow. You can be more prone to acute shunt obstruction, and the reason we don't see acute shunt obstruction so much in RV to PA is because there's this to and fro flow. But here with the BT shunt, that's where you're more likely to see it. And if you do go to an earlier bidirectional Glenn, it's usually from volume load to a single ventricle and CHF issues. So theoretically then, or not, the RV to PA provides a greater balance of PQ to QP to QS, so pulmonary to systemic perfusion in the postoperative period. There's no diastolic seal from aortic runoff, so there's improved diastolic blood pressure, more narrow pulse pressure than with the Norwood with the BT shunt, improved coronary perfusion, improved end organ perfusion, improved central PA growth. So some general principles of postoperative management, many of which the principles are somewhat the same from the pre-op that Trish talked about to the post-op, but there's some things you're doing different, and they're the same for both. The difference being that for the BT shunt, because your issues with increased pulmonary blood flow, it's sometimes harder to balance that in the immediate postoperative period. So the general principles include unobstructed intra-atrial communication, unobstructed systemic outflow via the neo-aorta and the aortic arch, optimal pulmonary blood flow through whatever shunt you're using, and you really want to maximize the ratio of oxygen delivery to oxygen extraction, and it's all about the appropriate shunt size. So if you put in too big of a shunt, then you're going to sacrifice systemic perfusion because you're going to get too much pulmonary blood flow. The caveat being is you have to put in a little bit of a bigger shunt because you have to allow for growth, so it's that balancing effect of that. So managing QPQS in the postoperative period is important, and I think Trish sort of went over the FIC principle for you. But the problem with the FIC principle, it's helpful, but when you do the calculation, it's the systemic oxygen saturation, so your arterial oxygen sat minus your mixed venous sat, which is from your SVC, so you can draw that value and get that, divided by the pulmonary venous oxygen saturation minus your arterial sat. The problem with this calculation is your pulmonary venous oxygen saturation is an assumed value. We're just plugging 95 in there, and we have no way of directly knowing because we're not directly measuring it. So you have to take this formula with a grain of salt, and this can be helpful, but you have to really use this formula with clinical assessment of hemodynamics and other indicators of cardiac function. So in this example, if your patient sat was 85 and you measured a mixed venous sat was 50 and you're assuming that the pulmonary vein is 95, then it would be 85 minus 50, which equals 35, divided by 95 minus 85, which is 10. So 35 minus 10, the QPQS is 3.5. So in this patient, he's getting a lot more pulmonary blood flow than is probably good for him. So postoperative management, so low cardiac output, increase in systemic vascular resistance, and myocardial dysfunction often occur in the postoperative period. And the medications that we often use are milrinone, nitroprusside, because it's all about decreasing your afterload, and that's what you want to focus on. Intraoperative phentolamine, which is it's a reversible non-selective adrenergic blocker, and or phenoxybenzamine, which we don't tend to use here, but Tweddle and colleagues in Wisconsin tend to use this a lot. The problem with both of these drugs is they have an extremely long half-life, and it's very difficult to reverse effects of phenoxybenzamine once on board, and you can only really do it with vasopressin. So we generally don't use that here. And vasopressor support would be important, and you want to avoid decreasing pulmonary resistance excessively. So caution should be used with manipulating mechanical ventilation to increase resistance to pulmonary blood flow to match SVR, because this will lead to pulmonary venous desaturation, causing decreased systemic oxygen delivery if you're not balanced with an increase in systemic outflow. So you got to be very careful with this, and this is more of an issue with the BT shunt. So manipulating the FCR is a more reliable way to manage QPQS rather than manipulating the PVR. So what are things that we normally would do? Correction of coagulopathy. You don't want to lose a lot of blood, so you can treat with blood products, but also it's important for preload. You want to keep your CVP up. And then if you want to keep your crit 45 to 50 to optimize oxygen delivery. So you want to be aware of that. Temperature control is very key, and the group here is trying to bring these patients up more closer to normothermic and not so hypothermic. Why is hypothermia bad for you? First of all, you don't clot very well, so you'll bleed more. But second of all, it increases your SVR. So if they're really hypothermic, that's not really good for output, right? So you kind of want them, and then conversely, you don't want them to get a fever even above 37 too much if they're really sick, because that's going to increase your myocardial demand and myocardial need for oxygen. So 36 to 37 is kind of where you want them, and you really should have a rectal probe or some continuous monitoring when they come up from the OR. You're going to monitor for tricuspid regurgitation and anything that's going to cause low cardiac output. And you want to minimize metabolic demand and stress with analgesia, sedation, pharmacological paralysis. And again, it's like your ventilatory maneuvers. You don't want to encourage too much pulmonary blood flow, so you're usually on an FiO2 of 21%. If it's a BT shunt, maybe a little higher for the RV to PA. You don't want to hyperventilate them. You have to be careful, so you're striving for the GAS of 740, 40, 40. And pulmonary reactivity, if you've had persistent pulmonary blood flow in the preoperative phase, that's going to predispose you to pulmonary hypertensive crisis in the postoperative period. So that can be an issue as well. We're looking to keep our mean arterial blood pressure somewhere between 40 and 50. If it's greater than 50, things you might want to consider are increasing your milrinone if not already, decreasing your inotropes if you can, maybe adding some nipride, even up to 4 mics per kilo per minute if you needed. If your blood pressure is too low and your CVP is low, then obviously it's a volume issue. But again, remember that crit, you want to maximize oxygen delivery, so a crit of 45 to 50 is probably better, and albumin otherwise. And a CVP of 12 or more, because at times your cardiac output improves with a higher CVP. So early indicators of inadequate systemic perfusion include low mixed venous saturation via the SVC and a rising lactate level. So, and a widening AVO2 difference. As you guys know, normal mixed venous sat for you and I, 2 ventricle is what, like 72 to 75, and we're 100% saturated. For a single ventricle patient, you look at their oxygen saturation, and there should be no more than a 25 to 30 point difference. So if you see on the monitor a sat is 85, that means your mixed venous sat should be about 50 to 55. If your oxygen sat is 75, then your mixed venous sat 45 to 50. So you get the gist of that. So when you have a widening AVO2 difference and your mixed venous sat starts to fall, it's a poor indicator of output and a higher risk of mortality and morbidity. And so your risk of animal aerobic metabolism increases significantly if your mixed venous sat is less than 30%. And in a study by Tweddle and colleagues in Wisconsin, they found that targeting a mixed venous sat of 50% post-Norwood procedure was the single most important factor in decreasing early mortality. So that's sort of where you want to look. So while lactate will rise as something's happening, it's actually a later sign, because once the lactate's risen, something's occurred. The first thing that's just changed is a mixed venous saturation. So it's a great idea to correlate your mixed venous sat with your NIRS. The near-infrared spectroscopy is on your forehead. It's monitoring cerebral perfusion. It's not an absolute value, but it will give you a trend. So it's a good idea to get your mixed venous sat, see what your NIRS is, and then follow the trend. If your NIRS is falling, that might be a good time to get your mixed venous sat or repeat it. So, and then things like metabolic acidosis and increased lactate are signs of poor perfusion, because as you remember, if you're not perfusing very well, you start breaking down instead of aerobic metabolism to anaerobic metabolism at a cellular level, and you spill lactate into your blood and you get acidotic. So, and it's actually the rate of rise of the lactate. I'm less concerned with the lactate that comes back at 8, maybe stays at 8 and 7, than one that goes to 3 to 5 in an hour. It's the rate of rise that's more important. So other signs of low cardiac output, decreased perfusion or tachycardia, decreased urine output, and low blood pressure is a late sign. So post-operative risk factors for poor outcomes include decreased mixed venous sat, less than 30, a lactate greater than 10, and rapid rate of rise. CVP greater than 15 to maintain an adequate blood pressure, An estimated QPQS of greater than 2 to 3, and moderate severe TR and an early postoperative echo, or anything that's causing obstruction to flow, anything that's going to affect your cardiac output. So managing acute shunt obstruction is an emergency that requires prompt intervention. So you should be listening for a shunt murmur, and if you see your oxygen sat drop precipitously, that's usually an indicator of acute shunt obstruction. How do you manage shunt obstruction? With volume to keep perfusion through the shunt, adequate analgesia and sedation, supplemental oxygen, a heparin bolus to stop the progression of a clot. It's not going to take away the clot, but it'll hopefully stop the progression. Interventional cath and re-op, and as you guys know, if these kids are going fast, they're going to be on ECMO pretty quick. And research indicates, both here, studies by Catherine Allen and colleagues and in CHOP, that if you go on for shunt obstruction or a reversible cause, it actually is a good outcome. You have a decreased mortality with it. So it is actually a reversible cause if you can catch it early. So it's well documented that malnutrition and inadequate growth are common in hypoplasts right after stage 1 surgery, and is associated with increased morbidity and increased length of stay. So I know I'm preaching to the choir here, but you want to optimize nutrition, and it starts in the ICU. Post-op day 1, you want to liberalize your fluids if you can to at least 100 cc's per kilo per day, and the goal is to get them on PN right away. The goal of 90 to 100 kilocalories per day, and you want to start enteral feedings as early as possible. As soon as you see signs of adequate systemic perfusion, you're peeing okay, your output seems better. Your goal is 120 to 150 kilocalories per day, and an optimal weight gain is 20 to 30 grams per day. And following a feeding algorithm has been shown to be a really effective way of advancing feeds safe and effectively and very quickly. And Nancy Broaddus' feeding algorithm and others is what we use generally in our ICU. So what are some diagnostic evaluation? Is the repair good, or are you worried about low cardiac output? What are the things you're looking for? You're looking for aortic obstruction, any AV valve regurgitation, so it's usually GR, aortic regurgitation, decreased ventricular function, the ratio of pulmonary to systemic blood flow, is there evidence of overcirculation or undercirculation, and the pericardial fluid, anything that's going to inhibit cardiac output or function. So this is a nice little, this is courtesy of Ravi, nice little graph I find really helpful, especially if someone's newer at the bedside. What's the scenario? Your SAT's 80, your mixed venous sat is 60, your blood pressure's okay, probably your QPQS is balanced, you usually don't need to do anything. Say a prayer and hope it continues. If your SAT is greater than 90 and your blood pressure is low, you probably have too much pulmonary blood flow rather than systemic. So is your SVR too high and your PVR is too low? Could it be arch obstruction? Could it be anything else that is obstructing flow out the aorta? Vasodilators may be helpful, or controlled hypoventilation. Is your SAT less than 75 and your blood pressure is decent or high? Then is it the reverse? Is you're not enough pulmonary blood flow, maybe more systemic? Is your PVR too high? Could it be a shunt obstruction? Any problems with that? So measures to decrease PVR, you want to increase your cardiac output, increase your crit in your oxygen delivery capacity. Is your SAT less than 75, your blood pressure is crappy, and your mixed venous sat is lousy? It's usually low cardiac output. Is it from something that's reversible? Is it AV valve regurgitation or arch obstruction? And then this is where you're going to probably be on more inotropic support and things to minimize stress. I'm not going to go over this in great detail because I know Jane Newberger has gone over the single ventricle trials, but the reason for switching to the Sono by most centers, and by the way, it used to be politically incorrect to say Sono because it was Norwood who invented it, but now people say Sono, it just is what it is. So as you know very quickly, the primary outcome for this first trial was death or transplant at 12 months. The secondary outcomes were unintended cardiovascular interventions, RV size and function at 14 months, transplant-free survival. And this early groups of patients, there was better transplant-free survival at 12 months with the RVPA conduit, and the greatest deaths occurred in the interstage period. And so I think she probably went over where we're at now. And we're probably, with the RVPA conduit, we're suffering maybe from RV dysfunction or things related to that type, but it's still a work in progress. So anyway, I'm not going to go over that because she did it already. But in summary, patients undergoing a stage 1 neuro procedure are at risk for labile hemodynamics and adverse events, including cardiac arrest. Postoperative management requires balancing QP and QS, reducing SVR, avoiding excessive pulmonary blood flow with excessive ventilation, enhancing myocardial contractility, prompt treatment of low cardiac output, close monitoring of mixed venous saturation and lactate, prompt evaluation and correction of residual anatomic lesions such as aortic obstruction, or anything that can cause low cardiac output. And in comparing the two operations, a stage 1 with the RVPA conduit prevents diastolic steal and allows better coronary perfusion. It improves hemodynamic stability in the postoperative period, is associated with improved survival at 12 months, and no significant difference in survival after 12 months of age.